Hello and welcome to the 5th lecture in our series covering the BSc Level 1 curriculum. In the last lecture we looked at colour Doppler and how to use this tool, and now we're going to consider some practical applications of this and how we can use the combination of colour and 2D imaging in order to have a look at the heart valves. There's lots to pack into this lecture. We're going to cover the normal anatomy of all 4 heart valves, how we visualise them during our Level 1 scan, how to make a very basic assessment of stenosis and regurgitation, and to consider the impact of those lesions in our sick patients. And then we're going to briefly touch on a few miscellaneous items. We're going to have a look at replacement heart valves and repaired heart valves. We're going to look at other areas where we may see increased velocity with our colour Doppler, so thinking about non-valvular stenosis. We're going to briefly touch on areas where we may notice other abnormal flow when using colour Doppler, so really thinking about shunt lesions there. And then we're going to talk quickly about how to look at the aortic root. Regardless of which of the valves you're looking at, and regardless to a degree whether it's a native valve or a replacement valve, your assessment will follow the same structure. So you're going to begin by looking at the 2D structure of the valve from all the available views, and consider are there the normal number of leaflets arranged in the usual configuration, and what about the thickness of the leaflets? Are they thin and open freely, or are there areas of thickening or calcification? Is there excessive motion of the leaflets? Do any of the leaflets flail or prolapse back into a preceding chamber? And are there any masses adherent to the valve, or destruction of the valve leaflets themselves? In a Level 1 study you don't have all of the tools required to perform a full valve assessment, and you're not expected to be able to accurately grade the severity of a lesion. But it is useful if you can decide whether or not you think that the valvular lesion that's present is likely to be hemodynamically significant, and the reason why the patient in front of you is sick. Finally, consider are there any sequelae of the lesions, and we'll talk about what these might be as we go through each valve in turn. So this diagram beautifully shows us the arrangement of the intracardiac valves and their relationship to each other. So here we can see the heart. If we imagine that we're looking through the atria which have been removed, looking towards the ventricles in the far distance. And we can see that the pulmonary valve, aortic valve and tricuspid valve are arranged superiorly to inferiorly, with the mitral valve posterior to the aortic valve. Understanding this arrangement is essential in being able to work out which valves and which parts of which valves, which leaflets in which valves we're looking at from our standard views. And we'll return to this diagram a number of times during this lecture when we're considering normal valvular anatomy. Alright, so let's first consider the aortic valve. So in the majority of individuals the aortic valve has got 3 leaflets, and each of these leaflets is named after the coronary artery that arises from the associated portion of the sinus. So the most anterior leaflet is the right coronary cusp leaflet, which is obviously associated with the right coronary artery. Posterior to this and to the left we have the left coronary cusp, above which arises the left main stem, and posteriorly and to the right we have the non-coronary cusp, so named because it doesn't have an associated coronary artery. In healthy individuals the aortic valve has relatively thin leaflets, and the central image here is a histology of the aortic root and valve. And you can see that the fibrous aortic valve leaflet is in continuity with the sinus of Valsalva. So in our Level 1 scan we're going to be able to visualise the aortic valve in a number of our standard views. So this is a parasternal long axis view, and here we can see that in the near field the right coronary cusp leaflet will always be visible, whereas the leaflet deep to this will be either the non or the left coronary cusp leaflet. And if your imaging sector is running through the centre of the valve, then you probably won't be able to tell which one you're looking at. The next view in which we see the aortic valve is a parasternal short axis view, at the level of the great vessels. Here we can clearly see all 3 cusps simultaneously. Obviously the right coronary cusp remains in the near field, with the left and non-coronary cusps posterior to this. It can be quite easy to get muddled between the left and non-coronary cusps, and a saying that may help you distinguish between the two is that the non-coronary cusp sits on the fence, where the fence here is the interatrial septum, clearly seen in this view. The third and final view in which we can see the aortic valve in the Level 1 minimum dataset is the apical 5-chamber view, and in terms of observing the aortic valve anatomy, this is probably the least useful. Firstly, if we consider how we view the valve, typically we'll move to the aortic 5-chamber view from an aortic 4-chamber view. So we start by placing our sector through the mitral and tricuspid valves, and then tilt the tail of a probe down such that the imaging sector moves anteriorly in the chest, up towards the aortic valve. So you can see that we're unlikely to bisect any of the coaptation lines cleanly. In addition, our probe is now further away from the aortic valve than it was in the parasternal position. So in this patient, on the previous clips, we had the aortic valve being about 7-8 centimeters from the probe, and now it's sort of close to 13-14. And due to attenuation, we get much less returning signal from deeper structures. And one of the key tenets to imaging a structure clearly is to try and get it as close to the probe as possible. Having said all that, this is a very useful view for us for using colour Doppler, because the flow of blood is much better aligned here with the ultrasound beams than we see in the parasternal position. Once you've identified the aortic valve, note the thickness of the leaflets, whether there's any additional calcification or thickening, and where this occurs, and whether the leaflets open freely during systole, or whether there's restriction that may be a sign of aortic stenosis. With a prevalence of 1 to 2%, whilst bicuspid aortic valves are not common, they're common enough that if you make a habit of scanning all of your sick patients, you will encounter them from time to time. Most commonly, bicuspid aortic valves appear to have 3 distinct leaflets, with 2 leaflets joined by a raphe, a band of fibrous tissue along the coaptation line. What are sometimes called true bicuspid aortic valves, where there are 2 symmetrical distinct leaflets, do occur, but are much less common. Okay, so let's have a look at some examples. So here we can see a patient with a tricuspid or tri-leaflet aortic valve, but there's heavy calcification of all 3 valve leaflets, with marked restriction in opening during systole. If we zoom in on the parasternal short axis view, and compare that with a patient with normal aortic valve opening, we can see just how limited the opening is. These images were taken as part of a more comprehensive study in which spectral Doppler was used to estimate the aortic valve area, which came out at 0.9 cm squared, which is consistent with severe aortic stenosis. This next clip is from an intraoperative TOE, demonstrating a bicuspid aortic valve. Here we have 2 sets of images, set 90 degrees apart, which are analogous to the parasternal short axis and parasternal long axis views that we obtained during TTE. Here in the left-hand image, the short axis of a valve, we can see fusion between the left and right coronary cusps with a raphe running between these. This is nicely demonstrated on this 3D image, which again shows the same structures as viewed from the aorta, looking in towards the left ventricle. In the long axis image, we can see one of the more common complications of bicuspid aortic valve, which is a dilated ascending aorta. So let's take a look at the 2 views in which we're going to use colour over the aortic valve, namely the parasternal long axis and apical 5-chamber views. In both of these examples, I've placed the colour box over what I consider to be a reasonable region of interest, assuming there's no specific pathology which needs to be demonstrated. In both the parasternal long axis and apical 5 chambers, the colour box should cover the aortic root, the aortic valve, the left ventricular outflow tract, and the septal basal portion of the left ventricle. The pathologies we're looking for here include the aortic regurgitation, which will arise at the aortic valve and travel back into the left ventricle, and turbulence within the left ventricular outflow tract. As always, a general principle is to limit the size of a colour box only to the region of interest, as large colour boxes have a negative impact on frame rate. Before we see any examples of pathology, we need to have a look at a normal case and understand what the normal flow of blood through the heart looks like. The velocity at which the blood moves is dictated by the pressure gradient between the chamber it's moving from and the chamber it's moving to. Under normal circumstances, when there's no resistance to flow, there should be negligible gradient between the 2 chambers, and hence all normal flow throughout the heart should be a relatively low velocity, rarely exceeding 1.5 meters per second. Having said that, when the ultrasound beam and flow of blood are well aligned, and hence the velocity is not underrepresented, even normal low velocity flow tends to exceed the upper limit of the scale, as we can see in the apical 5-chamber view, where a lasing is occurring. By contrast, abnormal flow within the heart is frequently high velocity. Let's consider flow across the aortic valve during normal ejection. Assuming there's no resistance to flow, there's no obstruction, then as LV pressure rises during systole, almost all of that pressure is transmitted across the aortic valve into the aorta, and aortic systolic pressure is almost identical to LV systolic pressure. Let's take a look at this diagram. So this shows us the different pressures within different cardiac chambers at different phases of the cardiac cycle. So we're thinking exclusively about the left heart here. So the left ventricular pressure is marked in blue, and the aortic pressure is marked in red. And as this diagram demonstrates, as the ventricular pressure rises, it reaches a point at which it exceeds aortic pressure, causing the aortic valve to open. And then in early systole, we have a situation whereby the ventricular pressure exceeds the aortic pressure, but assuming there's no obstruction to flow, then even when this pressure gradient is at its greatest, it's probably going to peak at around about 10mm of mercury. And that pressure gradient, somewhere in the order of 10mm of mercury, is going to produce a peak velocity across the entire outflow tract and aortic valve of around about 1.5 meters per second. By contrast, let's consider the difference between the aortic and ventricular pressure during diastole. So obviously, in order for LV filling to occur, the left ventricular pressure needs to fall below that of the left atrial pressure, which is typically somewhere in the order of single-digit millimeters of mercury. And whilst our diastolic aortic pressure falls below the systolic peak, in a patient with a competent aortic valve it's still going to be somewhere in the order of sort of 60 to 90 millimeters of mercury. And so we end up with a much greater pressure gradient, something like 50 to 80. And that greater pressure gradient will produce much faster flow velocities. And so if we now take a look at an example of aortic regurgitation as seen in the aortic 5-chamber view. So here we have two side-by-side images, on the left for plane 2D and on the right for 2D with colour. And in diastole we can see a discrete jet of mild aortic regurgitation arising at the valve and firing back into the left ventricle. And we can slow this clip down to make it more obvious. So we measured the velocity of this jet with spectral Doppler and it came out at 3.8 meters per second. And as you can see, that far exceeds the upper limit of our scale here. And so one key point to consider when using colour Doppler to assess regurgitation is the velocity of regurgitation is not a marker of severity of regurgitation. This high velocity of almost 4 meters per second, which persisted throughout all of diastole, simply tells us about the pressure gradient between the aorta and the left ventricle, and doesn't tell us about how much blood is travelling. So if we can't use velocity of a jet to help quantify our regurgitation, what can we do? Well, let's start by considering the anatomy of the jet, and how the jet appears on our image. So we can consider the regurgitation as having three discrete components. Initially we have the blood in the chamber distal to the valve, the blood that is going to regurgitate. As this blood travels back towards the valve, it begins to accelerate and becomes visible as domes of concentric colour. The blood then passes through the regurgitant orifice, and immediately distal to this we have the area where the jet becomes its narrowest, and we call this our vena contracta. And beyond this our jet then enters a preceding chamber, and this is the main body of the jet, the most obvious component of the regurgitant flow. You can consider that the vena contracta represents the narrowest point of the orifice, whereas both the flow convergence before the valve and the jet area after the valve both represent the amount of blood that is flowing. However, there are some important caveats to this. Firstly, we must consider how we've set our scale on our colour flow. So here you can see that the scale is set to 61 centimeters per second. Now that's the upper limit of the scale. The lower limit of the scale is roughly about 10% of the upper limit. So what that means is any flow in excess of 6 centimeters per second will be demonstrated by some shade of colour. So that red area at the top of the left ventricle is some slow flowing blood, but somewhere in excess of 6 centimeters per second. Anything below that level will not be represented. Now if we were to set our scale at a different level, say one much lower, then we would detect and start to represent much slower flows, exaggerating the size of a jet area. When assessing regurgitation, our scale should be set somewhere between 50 and 70 centimeters per second. So here at 61 centimeters per second, we're just perfect. This table covers some of the factors that will impact on the size of a jet area. Now we've already discussed Nyquist limit, which is the scale that the colour box is set to, but we should also consider momentum, which is the key determinant of the size of a jet, which is dictated by the size of the regurgitant orifice and the velocity of the travelling blood. So as we've mentioned several times before, the velocity is largely dependent on the pressure gradient between the two chambers, and so it's important to consider the patient's blood pressure. With respect to aortic regurgitation, a low aortic diastolic blood pressure will reduce the gradient between the aorta and the left ventricle, reduce the velocity, reduce the momentum, and reduce the jet area. We can see this phenomena for all of our valves, and it's particularly important for the mitral valve, where low systemic systolic blood pressures can sometimes lead to underestimating the severity of mitral regurgitation. Finally, sticking with momentum, we need to consider the significance of the angle of the jet, whether it's central or eccentric. Jets which are angled against a chamber wall will lose their momentum more quickly, and this is just one of the reasons why the severity of eccentric jets is often underestimated. We'll see some examples of this when we consider the mitral valve later on. I think the best thing to do now is take a look at some examples of aortic regurgitation of varying severities, so that we can see how the images evolve as the severity increases. So first up we have some images taken from an elderly patient presenting with a spontaneous hypertensive intracranial hemorrhage, who subsequently developed pulmonary edema. And here we have both their parasternal long axis view and apical 5-chamber view, with a colour box placed to pick up aortic regurgitation. Our Nyquist limit is appropriately set, and in the parasternal long axis view we can see a thin sliver of AR that I would consider trivial. Whilst it can just about be seen in the apical 5-chamber view, the majority of flow that you can see is the normal filling from the left atrium to the left ventricle through the open mitral valve. Whilst AR is never normal or physiological, this tiny amount of AR is unlikely to be contributing to why the patient is sick. These images are taken from an elderly gentleman who has just dropped his blood pressure following evacuation of the subdural hemorrhage. This patient has a tricuspid aortic valve, but the leaflets are thickened and there's restriction of the left coronary cusp. And here in the parasternal long axis view we can see a narrow jet of AR that originates centrally but is directed across the anterior mitral valve leaflet. In the 5-chamber view, the eccentric jet blends with the normal LV filling, making it difficult to discern. This AR was considered to be mild and not related to the patient's changing condition. This next set of images are taken from a gentleman in his mid-60s who presented with acute pulmonary edema. Here in the parasternal long axis view, we can see a jet of aortic regurgitation that arises centrally and is directed centrally through the left ventricular outflow tract. Whilst one way to better assess the flow of blood is to slow the image down, an alternative way of getting a sense of these changes over time is to use colour M mode. To do this, first set up a standard colour flow image, then place your cursor through the outflow tract, proximal to the aortic valve, and then select the M mode function to create an M mode graph. Here we can clearly see systole and diastole, with relatively slow flow during systole and then a narrow jet of fast flow during diastole. You'll remember that when using colour, any malalignment between the flow of blood and the direction of the ultrasound beams will lead to an underestimate of velocity, and that's certainly happening during systole when the ejected blood is displaying laminar flow. However, the regurgitation inside the outflow tract is turbulent, with flow in all directions, including towards and away from the transducer. This, along with the relatively faster velocities of aortic regurgitation, means we're unlikely to miss significant AR due to malalignment. In comprehensive echo, where it's necessary to grade the severity of AR formally, the proportion of the outflow tract diameter that fills with the AR jet is one of our markers of severity, with jets less than 25% the outflow tract diameter suggestive of only mild AR, and jets in excess of 65% of the outflow tract diameter suggestive of a severe lesion. Whilst you're not expected to measure the outflow tract or the AR jet, you can quickly eyeball their relative sizes, and here I would estimate that the jet occupies somewhere between 1/5 and 1/4 of the outflow tract diameter. This next example is from a female patient who presented to the emergency department with severe chest pain on the background of several months of increasing breathlessness. Here we can see her parasternal long axis view and apical 4-chamber view, and in the 2D images we can immediately see some striking abnormalities. Chief among these is a severely dilated aortic root, measuring approximately 6.5 centimeters across the sinus. In addition, the left ventricle is dilated, and whilst the LV cavity diameter in diastole was just 50 millimeters, so at the upper limit of the normal range for a female patient, when we estimated the LV diastolic volume using the Simpson's biplane method and indexed it for a body surface area, this came out at 100 mils per meter squared, which is on the border of moderate to severe dilatation. The LV systolic function is severely impaired, with an ejection fraction around 25 to 30%, and the left atrium is also dilated, and there's fixed bowing of the intraatrial septum from left to right, consistent with elevated left atrial pressure. If we replace our apical 4-chamber view with an apical 5-chamber, we can again see a very large aortic root, and by placing colour flow boxes over these two images, we can appreciate the severe aortic regurgitation. The dilated and impaired left ventricle in this patient suggests that the aortic regurgitation is likely to be chronic. The months of breathlessness probably relate to poor left heart function and raised left atrial pressure, whilst the dilated aortic root and history of sudden onset of chest pain should raise the suspicion for aortic dissection. And indeed, whilst we can't see the aortic dissection flap within the aortic root on this image, it was possible to see a clear aortic dissection in the abdominal aorta when panning to the left from a standard subcostal IVC view. Type A aortic dissection was subsequently confirmed on a CT aortogram. This case nicely leads us on to think about the consequences of aortic valve lesions. One consequence of chronic aortic stenosis may be the development of concentric left ventricular hypertrophy, that is, thickening of the walls with a preserved cavity diameter. This certainly doesn't always occur, but it may occur as an adaptive response in order to maintain normal LV wall tension. Reduction in LV systolic function as a consequence of aortic stenosis is a late feature, but importantly, if the LV function is impaired because of high LV afterload, then aortic valve replacement may result in a rapid improvement in LV function. When the 2D morphology of the aortic valve leads you to suspect aortic stenosis, it's worth asking if the LV walls are thickened, as this would clearly support this diagnosis. In contrast, chronic aortic regurgitation typically results in progressive dilatation of the left ventricular cavity, whilst the LV geometry changes such that the cavity becomes more spherical. Initially, the left ventricular ejection fraction is preserved within the normal range, and again, a reduction in ejection fraction is a late feature, and this impaired LV systolic function may be irreversible by the time it's detected. Okay, so now let's leave the aortic valve and go posterior and inferior so that we find the mitral valve. So when we consider the normal anatomy of the mitral valve, we typically describe it as having 5 key components, which are the fibrofatty annulus, the 2 mitral valve leaflets, with a larger leaflet, the aortic or anterior leaflet, which is adjacent to the aortic valve, and then opposite this we have the mural or posterior leaflet, which is smaller by area but occupies a larger proportion of the circumference of the annulus. And then beyond this we have the subvalvular apparatus. So arising from the left ventricle walls, we have the posteromedial papillary muscle and the anterolateral papillary muscle. The posteromedial papillary muscle arises from the mid-inferior wall and is typically supplied by branches of the right coronary artery, and it sends off chordae to the posterior and medial portions of both the anterior and posterior mitral valve leaflets. The anterolateral papillary muscle arises from the mid-anterolateral wall, as you might imagine, and this sends off chordae to both the anterior and posterior leaflets, and this time to the anterolateral portions of those leaflets. The chordae can be divided into primary chordae, which attach to the leaflet edges, and secondary chordae, which attach to the rough zone, which is the ventricular surface just before the leaflet edge. If we look at this photo on the left here of the mitral valve, this is taken from within the left atrium looking down towards the left ventricle, and we can see at the bottom of the image the posterior mitral valve leaflet, and we can see there are clefts running within the posterior leaflet, so that it's divided into 3 anatomically separate scallops, and by convention we label these P1, P2 and P3, with P1 being the most anterior and P3 being the most posterior. The anterior mitral valve leaflet doesn't have these same divisions, not anatomically, but we still label it A1, A2 and A3, as this helps us describe the location of abnormalities. It's important for echocardiographers to understand that for the valve to function correctly, all of these components, the annulus, the valve leaflets, the papillary muscles and their chordae, and the ventricular walls from which they arise, must all be working properly, and an abnormality in any of these structures can lead to valvular incompetence. Okay, so let's consider how we visualise the mitral valve in our standard level 1 views. So this is a parasternal long axis view, and here we can see both the anterior leaflet in the near field and the posterior leaflet in the far field, and you can see how that when we cut through the centre of the LV cavity, our imaging sector passes through A2 and P2. We are unlikely to visualise the papillary muscles unless we angle our imaging sector inferiorly and miss the centre of the cavity, but we will see chordae projecting from the cavity up to the leaflets. So this slice through the centre of the LV cavity is fine if the pathology is bang in the centre of the mitral valve, but if you have a lesion away from the centre you're going to miss it. And so for all valves, but particularly for the mitral valve in this view, it's important to tilt the probe such that you pan through the valve. So here for the mitral valve, when you're in the parasternal long axis view, take the body of a probe, lower it towards the patient's right hip. Doing so will make your imaging sector move anteriorly towards A1P1. Once you've moved beyond the mitral valve in the anterior direction, lift the body of a probe such that the imaging sector moves posteriorly, down through the centre of the valve, and beyond A3P3. Whilst it's important to pan through the valve in 2D imaging, it's particularly important when you're using colour over the valve, and you're assessing for regurgitant jets which may well be eccentric and away from the centre. We next encounter the mitral valve in the parasternal short axis at the basal level, And here we can see the mitral valve on face. We can see all of the valve, with the anterior leaflet in the near field and the smaller posterior leaflet in the far field. We can see the entire length of the coaptation line, and this view of the valve and the valve orifice is often said to resemble a fish mouth. Our next view of the mitral valve is in the apical four-chamber view, and here we have an oblique cut through the valve leaflets, with the anterior mitral valve leaflet being closest to the intraventricular septum, and the posterior leaflet is lateral, on the right-hand side of the image. In this view we can often see the anterolateral papillary muscle projecting into the LV cavity and sending chordae down to the valve leaflets. We can achieve a similar four-chamber view utilising the subcostal window, which again leads us to cut obliquely through the mitral valve. We can apply colour boxes over the mitral valve in any of these views to look for turbulent antegrade flow or the retrograde flow of regurgitation, but as part of a minimum dataset we do it in just two views, the parasternal long axis and the apical four-chamber. Once again, the scale should be set to between 50 and 70 cm per second, and the box should be placed such that it covers the mitral valve leaflets throughout the entire cardiac cycle, as well as the left atrium. Only the basalmost portion of the left ventricle needs to be covered, as we're principally using this colour box to look for regurgitant jets. Alright, now we've seen some normal mitral valves, let's take a look at some pathology, and we're going to start with mitral stenosis. So worldwide, the most common cause of mitral stenosis is secondary to rheumatic heart disease, but this exhibits significant geographic variation, and almost exclusively affects patients who grew up in developing countries. If you're practicing in a more affluent country, like the UK, then you'll most commonly see rheumatic mitral stenosis in patients who grew up in a country in which rheumatic fever is endemic. In rheumatic MS we see thickening of the leaflet edge and fusion of the commissures. However, the leaflet far from the edge remains relatively pliable. This means that during diastole, when blood is passing from the left atrium to the left ventricle, the position of the anterior mitral valve leaflet tip is fixed, but the leaflet away from the edge bows out into the LV cavity, producing a classical hockey stick appearance. In patients who grow up in developed countries, the most common form of mitral stenosis is secondary to mitral annular calcification. Calcification around the annulus is really common, and you'll definitely see this in your elderly patients. And as this progresses, you see calcification extending from the annulus towards the leaflet tips, slowly encroaching inwards. This too will present with restricted opening during diastole, but without that hockey stick appearance. So let's have a look at an example. So this is from a middle-aged female patient who was intubated for severe pancreatitis, and this echo is performed as she failed to wean from mechanical ventilation, developing pulmonary edema each time the ventilatory support was reduced. And here we can see she has thickened mitral valve leaflets, with a very narrow opening in diastole, here highlighted in green. If we swap out our apical four-chamber view and replace it with a parasternal long axis, with colour over the mitral valve, we can see that this patient has mixed mitral valve disease. So there's turbulent high-velocity jet of blood passing from the LA into the LV during diastole, but in addition there's also significant mitral regurgitation. In the 2D image we can also see that the left atrium is dilated, and this is a common feature of mitral stenosis. This 2D still on the right is taken from a different patient who's developed severe left atrial dilatation as a consequence of their mitral stenosis. And this video clip on the left shows the most extreme example I've ever seen, where we've had to extend the depth out to 24 cm to get all of the left atrium in, and this cavity absolutely dwarfs the rest of the heart, with the LV appearing as just a tiny triangle at the top of the image. If left unchecked, mitral stenosis may lead to pulmonary hypertension, and so the echocardiographer should look for and comment on the presence of RV dilatation, hypertrophy of the RV free wall, and whether or not there's any reduction in RV systolic function. Okay, so let's turn our attention to mitral regurgitation. So when assessing mitral regurgitation, there are two key questions that the level 1 sonographer needs to ask themselves. Firstly, and for our purposes most importantly, what is the severity of the lesion? And secondly, what is the etiology? Why does this patient have mitral regurgitation? We'll consider these two questions separately, but of course they are intrinsically linked. Now, grading the severity of valvular lesions, including mitral regurgitation, is tricky even in the most experienced hands. And for level 1 sonographers this is particularly true. What are some of the reasons for this? Well, first of all, you don't have a complete toolbox. This table here shows you some of the criteria that we use to help grade chronic MR, and you can see that by relying exclusively on 2D and colour flow imaging, a large number of those criteria aren't available to you. What you're left with is considering the 2D morphology of a valve, so a valve that looks structurally abnormal is more likely to have severe incompetence. And looking at the colour flow both before the valve in terms of a flow convergence, but probably more importantly for the level 1 sonographer, after the valve lesion in terms of the jet area, where a large visible jet indicates a greater degree of mitral regurgitation. And of course all those factors that we discussed when considering aortic regurgitation, factors that impact on the visible jet area, are still important when considering mitral regurgitation. And probably the two most important for the level 1 sonographer to consider are the impact of systemic blood pressure and the impact of the direction of the jet, with eccentric jets which hug the wall losing momentum quickly and having the potential to be under-recognised. Facing all of these challenges, the level 1 sonographer is not expected to be able to accurately grade the severity of valve lesions. And if we take a look at the level 1 reporting template, we can see there's a deliberate move away from using the terms mild, moderate and severe, and instead the reporting template includes the word significant. So just a word on this, because I know it can cause confusion, certainly amongst my own trainees. What is it that we mean when we use the word significant here? Well, to me in this context, I think the word significant means contributing to the reason why the patient is sick, either as the primary reason or as a substantial secondary contribution. If we're performing a study because the patient is shocked, they're hypotensive and unwell, and we see a structurally normal valve with only a very small central jet of regurgitation, then it's unlikely that the MR is the reason why they're unwell. Conversely, if the valve looks destroyed by vegetations and we see multiple large jets of MR firing off back into the LA, well, that seems like a very plausible reason for why our patient is sick. So as I mentioned earlier, as well as considering severity, we should consider etiology. And this is because wherever possible we should try and tie all of the findings of the echo together, and together with the patient's clinical history and examination, in order to produce a narrative which makes some sort of sense. So one way of describing the different etiologies of MR is to divide them up into primary and secondary, where primary MR is due to a structural abnormality of the valve leaflets themselves, or the subvalvular apparatus, whereas in secondary MR you have a structurally normal valve leaflet, but it functions ineffectively due to ventricular remodeling. Another way to consider mitral regurgitation etiology is using the Carpentier classification. This classification system breaks down the causes of MR as to whether or not they cause normal, excessive or restrictive motion of the mitral valve leaflets. This way of conceptualizing the causes of MR is relatively straightforward for the level 1 sonographer, because it's usually possible to detect excessive or restrictive leaflet motion on 2D imaging. And in addition, certain patterns of abnormal leaflet motion produce characteristic patterns of the MR jet as seen on colour flow. We'll take a look at a number of examples of each of these types in a second, but before we do, let's consider what sort of jet we might expect to see if we had an isolated lesion of a single leaflet demonstrating abnormal motion. So if we take a look at this graphic, if we imagine that the left-hand leaflet is completely normal and the right-hand leaflet has restricted closing during systole, here we can see that the MR is directed underneath the abnormal leaflet. So with restrictive leaflet motion, MR is directed towards the leaflet with the problem. What if the issue is not restrictive leaflet motion but rather excessive leaflet motion? So here our right-hand leaflet is prolapsing back into the left atrium, and now the MR jet is directed away from the abnormal leaflet. This series of illustrations demonstrates some of the common causes of mitral regurgitation, and in each illustration the red arrow demonstrates the direction the regurgitant blood is expected to take. Of course, all of these assume that you have an isolated lesion, whereas in reality it's not uncommon for there to be more than one lesion present. Let's take a look at a number of examples of mitral regurgitation, and in each case we're going to consider the severity and the etiology. So this first example is taken from a middle-aged male healthy volunteer with no symptoms and an essentially normal echocardiogram. In the 2D images we can see the mitral valve leaflets open fully during diastole and then come together during ventricular systole, with no prolapse back into the left atrium. The LV cavity is of normal size, with normal systolic function, and the LA is also of normal size. And if we look at the images with colour flow and slow them down, and then pause during ventricular systole, we can see a small amount of mitral regurgitation. And if I were formally reporting this echo, I'd consider this to be trivial, and for the purposes of a level 1 scan, I'd consider this to be insignificant. Here we have another example of trivial or insignificant mitral regurg. These images are taken from an elderly patient who developed Takotsubo stress cardiomyopathy following a spontaneous subarachnoid hemorrhage. This study was performed several days later to ensure that the LV dysfunction had resolved. In the colour flow images we see a small flash of blue on the atrial side of the mitral valve, and slowing this down and freezing this we can see the trivial MR. MR of this magnitude won't be hemodynamically significant, and if you miss it in your level 1 scan it's far from the end of the world. But seeing as it's common, and you will see examples of it in your real life practice, I feel it makes sense to show a couple of examples here. So if these are both examples of insignificant mitral regurg, let's have a look at some examples of significant MR. So these images are taken from a gentleman in his late 80s who'd just been brought round from the operating theatre to the ICU following an emergency laparotomy. And this study was performed as the patient was in a shocked state, requiring a significant amount of vasopressor support. We can see that the LV contractility is reduced, and this is consistent with the patient's known ischemic cardiomyopathy. And in the colour flow images we can see a central jet of functional MR, which is probably moderate in severity. So this next case is from a female middle-aged patient who presented with several months of dyspnea. And if we start with the 2D parasternal long axis view, we're immediately struck by the dilated left ventricle, which exhibits poor contractility during systole. If we focus on the mitral valve, we can see that it doesn't open terribly well during diastole. It's not flung open. However, the leaflets themselves aren't terribly thickened or calcified, and the most likely cause of this here is just low flow across the mitral valve. During ventricular systole we can see the leaflets close and come together, but even on the 2D imaging we can see the leaflets don't actually meet. So in the normal mitral valve there should be an area of coaptation, a zone of coaptation, extending about 5 to 10 mm from the valve leaflets. And when your leaflets don't meet and there's a visible gap, you have to expect you're going to find some severe mitral regurgitation. And indeed that's exactly what we do find. So unlike the previous case where we had a discrete jet of mitral regurgitation originating centrally and firing into the centre of the LA, here our left atrium is completely filled with colour during systole. Indeed, this is the sort of case where when you're first using colour, there's the potential to be caught out, as rather than seeing a beautifully defined jet, we're left with a bit of a mess. So if you're uncertain, slow your clip down, freeze it if you need to, and I apologise because the ECG here isn't very easy to read, but take my word for it, this is early systole. And here we have a left atrium completely full of high velocity flow. If we take a look at the apical 4-chamber view, this confirms what we know about the dilated and poorly functioning left ventricle, and with colour placed over the left atrium, we can see that even though the LA is dilated, the jet fills the majority of the LA area. Slowing the clip down and then pausing it allows us to clearly identify the three components of regurgitant flow: the flow convergence, vena contracta and jet area. And I've paused this clip in particular and highlighted the vena contracta here because I think this is a nice example of where we need to use caution in estimating the severity of regurgitant flow. So we imagine that the diameter of a vena contracta roughly approximates to the diameter of a regurgitant orifice. But it's important to remember that the orifice may not be perfectly circular, and when it isn't, the angle through which we bisect the orifice is important. If we consider that in the apical 4-chamber we cut obliquely through the leaflets, then the diameter of a vena contracta would be the same, regardless of whether or not our orifice was centred exclusively on the scan plane, or rather extended along the entire coaptation line. Clearly the latter is a much more serious lesion, and will allow far more regurgitant flow. If we look at the mitral valve from a parasternal short axis view, we can see that a large part of the etiology of this MR is angular dilatation, pulling the leaflet edges apart, such that they fail to meet along the entire length of the coaptation line. Placing a colour box over the mitral valve here gives a much better indication of the size and shape of a true regurgitant orifice. This next case is an example of mitral valve leaflet destruction due to infective endocarditis, occurring in a middle-aged lady who presented with predominantly respiratory symptoms. Here we have side-by-side parasternal long and short axis images, and we can see a vegetation arising from a posterior mitral valve leaflet, leading to leaflet perforation. As we would anticipate from the 2D clip, this leads to severe mitral regurgitation. The severity of the MR here is so great that it doesn't form a distinct jet like we've seen in some of the previous examples. Rather, it completely fills the entire LA cavity during systole. If you're ever uncertain whether you're seeing abnormal flow or not, pause your clip and advance frame by frame, paying attention to which phase of a cardiac cycle the flow is occurring. These next images are taken from a young man presenting with breathlessness, whose echo revealed a dilated cardiomyopathy of uncertain origin. When placing colour over the mitral valve, we can see that the jet is angled underneath the posterior mitral valve leaflet. As the anterior leaflet isn't prolapsing back into the left atrium, we can deduce that the most likely etiology here is posterior leaflet restriction. If that last case was an example of restricted mitral valve movement, what about a case of excessive movement? So this is a intraoperative TOE of a patient undergoing mitral valve repair for prolapse of the P3 scallop of the posterior mitral valve leaflet. So I appreciate you won't be familiar with these views, so if I talk you through, you've got the left atrium in the near field, with the apex of the left ventricle disappearing off in the far field. And on the right hand side of the image with the anterior mitral valve leaflet, and obviously on the left that gives us the posterior leaflet. And we can see here that in systole the posterior leaflet falls back below the annular plane, falls back into the left atrium, but the leaflet edge continues to point towards the left ventricle, so it's not completely flail. Alright, so let's wrap up these examples of MR with one final case study. So these clips are taken from an elderly lady who presented in respiratory extremis, having had progressive shortness of breath over about 4 days. She required intubation immediately on presentation to the ED, and this lady was a smoker with a history of COPD, so she had no parasternal windows to speak of. And so let's start by going to a subcostal window. And what we notice straight away is whilst the right ventricle is working quite well, there's something wrong with the contractility of the LV, and in particular the anterolateral wall doesn't appear to be moving properly. In addition, the LA is dilated and there's fixed bowing of the intraatrial septum from left to right, telling us that we've got a high left atrial pressure. Now, as we don't have any parasternal windows, this is a subcostal short axis, and this is an oblique cut, so walls aren't necessarily directly opposite each other. What we can see is that there's regional variation in the contractility, with the inferior and inferolateral walls being markedly hypokinetic when compared to the hyperactive anterior segments. In addition, we can see some tissue flapping around within the LV cavity, adjacent to one of our hypokinetic walls. Now, as you can see, the apical windows were quite challenging, but we could just about get a view. And if we zoom in on the mitral valve, we can see that in systole we have a flail posterior mitral valve leaflet. If we then apply a colour box over the mitral valve, then we can see a jet of eccentric MR directed away from the flail posterior leaflet and underneath the anterior leaflet. A 12-lead ECG was consistent with posterior STEMI, and she was taken to the cath lab where she underwent PCI to the left circumflex. She subsequently had a TOE performed on the ICU, which confirmed the etiology of the MR. Here on the left we can see a 3D reconstruction of the mitral valve, and we can imagine that we're viewing the valve from the left atrium looking towards the left ventricle, with the anterior leaflet superior and the posterior leaflet inferior. And here I've highlighted the flail segment, which is the anterior and lateral portion of the posterior leaflet. On the right we have a second 3D image, and this is looking at the anterolateral papillary muscle, where we can see that one of the two muscle heads is ruptured. We've got a clean shear across the muscle body, and so then there's nothing holding all those primary chordae to the LV wall. Let's wrap up the mitral valve by considering the consequences of significant mitral regurgitation. And it's key to remember that the chronicity of the lesion is just as important as the severity. When you have sudden, severe acute mitral regurgitation, the heart won't have had time to adapt, so the LA and LV size will normally be normal, or only mildly dilated. Importantly, the left ventricle function will often appear hyperdynamic, as it's easy for the left ventricle to eject blood. It can eject blood forward into the systemic circulation, or backwards into the lungs. One concept that's absolutely essential for the level 1 sonographer to understand is that when you have severe MR, not all of that blood is going to go forward, and so it's possible to have a normal ejection fraction and yet still be in cardiogenic shock. In the chronic state we see both dilatation of the LV and LA as the heart adapts to deal with the increased blood flowing between the two. Ultimately we might see a reduction in the LV contractility, and just as with AR this is concerning as by the time it's recognised it may be irreversible. As the LA dilates, the LA pressure increases, and we may see downstream consequences of pulmonary hypertension on the right heart. Okay, so this is probably a good time to turn our attention to the right heart and to right heart valves. Now in the level 1 syllabus, not as much attention is given to the right heart valves as to the aortic and mitral, and this is because lesions of these valves are much less likely to be hemodynamically significant in the context of an acutely unwell patient. Nevertheless, we do see these valves during our study, so we'll spend just a few moments revising their anatomy, how they appear on echo, and what assessment we need to make. So let's start by considering the tricuspid valve, and this valve shares a lot in common with the mitral valve that we've just covered. So in terms of anatomy, we have an annulus from which arises a number of leaflets, and here obviously we have 3 leaflets, which are most commonly termed the septal, anterior and posterior leaflets, with the anterior typically being the largest, followed by the posterior, and the septal being the smallest. Then within the ventricle we have a number of papillary muscles arising from the ventricular walls, which send off chordae to the leaflets themselves. The exact number and distribution of these papillary muscles varies patient to patient, and in level 1 echo we're not too concerned with the RV papillary muscles, but it is helpful to understand that just as for the mitral valve, all of these components need to be working together for the tricuspid valve to remain competent. Whilst the tricuspid valve is visible in both the parasternal short axis and subcostal windows, it's in the apical four-chamber view that we pay the most attention to it. Just as with the aortic valve in the parasternal long axis view, it's not always possible to know which of the tricuspid leaflets is visible. In the apical four-chamber view it will be the septal leaflet, adjacent to the intraventricular septum, but the leaflet arising from the free wall could conceivably be either the anterior or posterior leaflet, depending on how the probe is angled. Lifting the body of the probe will move the imaging sector inferiorly, revealing the posterior leaflet, whilst lowering the body will move the imaging sector superiorly, and bring the anterior leaflet into view. The apical four-chamber view is also the only one in which we use colour over the right atrium and tricuspid valve in our level 1 minimum dataset. Both this 2D and colour clip are from the same healthy volunteer, and here we can see a tiny, trivial or insignificant jet of central TR, which is a common finding in healthy individuals. Another important consideration is that the tricuspid valve has multiple coaptation lines, and therefore depending on the etiology of the regurgitation, it's very possible to have multiple eccentric jets coexisting, and how the jet appears on echo will vary depending how it's bisected. This 2D clip is taken from an elderly patient with a history of previous tissue aortic valve replacement and COPD leading to pulmonary hypertension and RV dilatation. From the 2D image alone we can see that the RV is indeed significantly dilated, and we would expect to find functional tricuspid regurgitation due to annular dilatation. And indeed, when we first apply colour to the right atrium, we find a narrow jet of colour originating at the coaptation line and directed towards the intraatrial septum. But as a proportion of the right atrial area, this jet does not appear that great. This highlights the importance of tilting the probe and panning throughout the valve, as here we can see a very subtle change in angle has revealed a much greater jet. Okay, so finally let's consider the pulmonary valve, which is structurally very similar to the aortic. The pulmonary valve lies slightly anterior and superior to the aortic valve, and like the aortic valve, it typically has 3 cusps and doesn't rely on any subvalvular apparatus. The leaflets get their name from their relationship to the paired aortic valve leaflet, so the leaflet adjacent to the right coronary cusp of the aortic valve is a right pulmonary leaflet, and the left. This leaves one remaining leaflet, which is sometimes termed the non-facing leaflet or the anterior leaflet. In the level 1 minimum dataset, the only place we're likely to see the pulmonary valve is in the parasternal short axis view, where it's found just to the right of the right coronary cusp of the aortic valve. In a focus study you're not expected to make any sort of assessment of this valve, but it is important to recognise it, as every once in a while you'll discover an abnormality such as pulmonary valve endocarditis. In contrast to the left heart valves, acquired lesions are rare. However, a small amount of pulmonary regurgitation is a common finding in healthy individuals. So far we've been exclusively concerned with native heart valves, but even if you don't work in a cardiac centre, you will encounter replacement heart valves in your day-to-day practice. Now, imaging replacement heart valves is really tricky even for experienced sonographers. To start with, views can be challenging due to acoustic shadowing, and there are a wide range of replacement valves available, each with slightly different characteristics, and it's impractical for anyone to be expected to be familiar with all of these. For the level 1 sonographer, the key questions when facing a replacement heart valve are exactly the same questions you ask when thinking about a native valve. So does it open, does it allow blood through, and when it closes, is there any incompetence, any regurgitation? If there is regurgitation, does it occur through the valve, i.e. transvalvular, or around the sewing ring, i.e. paravalvular? Knowing how challenging it is, you should have a low threshold for seeking a second opinion. Whilst replacement valves are not the focus of this lecture, I would like to show you a few examples of some of the common types that you will find in your practice, so at least you'll be able to recognise them when you see them. So first of all, let's consider mechanical replacement valves, and this is one of the most common types that you'll encounter, which is a bi-leaflet valve, with two semicircular leaflets held to a fixed ring with hinges at either side. These are durable but require full anticoagulation to prevent thrombus forming on them. They are highly reflective, making them very difficult to image. This clip here is from a mid-esophageal two-chamber view taken during cardiac surgery. In the near field we have the left atrium, and in the far field we should be able to see the left ventricle, but it's rendered entirely invisible due to the acoustic shadowing. With the clip frozen in systole, we can see two areas of flow back into the LA. We have washing jets which are entirely intentional and are caused by deliberate flow of blood through the hinges in order to wash out any thrombus which might be forming here. And in addition we have a large paravalvular leak at the lateral aspect of the valve. This 3D clip is taken from the left atrium looking towards the valve and through into the left ventricle, and it nicely highlights why the patient is experiencing such a large paravalvular leak, as there's an area of dehiscence along the lateral aspect. This next clip is another mid-esophageal two-chamber view, and highlights another danger of these valves. Here we can see a large thrombus has formed, rendering one of the leaflets completely immobile, and restricting the motion in the second leaflet, which has led to severe mitral stenosis, mitral regurgitation and elevated left atrial pressure. This patient was successfully treated with thrombolysis. Just as with metallic valves, there are a wide range of tissue valves available. This is an example of a stented bioprosthesis, where a synthetic frame is used to mount either porcine valve leaflets or bovine pericardium. This study was performed in a patient immediately post-op mitral valve replacement, and in this apical 4-chamber view the valve appears to be functioning well. This next set of clips is taken from a different patient, from a middle-aged lady who had previously had a tissue mitral valve replacement and was now presenting with fevers. Here we can see a stented bioprosthesis in the mitral valve position, and rather than seeing nice clean leaflets, we can see additional tissue within the sewing ring that is highly suspicious for prosthetic valve endocarditis. Studying the valve in the apical 4-chamber view only compounds this. Percutaneous transcatheter valves are growing in popularity, in a large part because they can be offered to patients who wouldn't be suitable for conventional cardiac surgery. This next clip is from a patient who has just deteriorated following a TAVI procedure. The TAVI couldn't be well visualised in the parasternal or apical 5-chamber view, and so this is an apical 3-chamber view, which you can imagine is a mirror image of the apical 5. So here we've got the left ventricular outflow tract and the aortic valve position to the right of the mitral valve as we see it. The leaflets are invisible, but we can see two bright parallel lines which represent the frame of the TAVI. The valve appeared to be working well and was not felt to be the reason for the patient's deterioration. Okay, so I hope these few cases demonstrate just how difficult it can be to visualise replacement valves on echo. And the key point to remember is you're not expected to be able to do detailed valvular assessments of either native valves or replacement heart valves. With both of these, and particularly with replacement valves, it's very easy to either under or overcall abnormalities. And if you're ever unsure, you definitely need to be getting expert help. Okay, so I'd like to move away from valves for a few minutes, and seeing as we're now using colour for the first time in our clinical assessment, let's consider a few common situations where we'll see abnormal flow, so that when we do see it we recognise it and recognise its importance. And the first situation I want to consider is intracardiac shunts, so defects within the heart that lead to usually left to right but occasionally right to left flow. Congenital heart disease is a huge topic which requires dedicated training, so this is really meant to be just a very brief overview of some particularly common lesions. So if we start with the atria, and start with not a true defect, but rather a variant that's so common it can almost be considered a normal variant, and that's a patent foramen ovale, or PFO. These aren't true defects because there's no absence of tissue, and if the atria aren't dilated, and the left atrial pressure is slightly higher than the right atrial pressure, then these tend to act as a valve, so no flow across. This TOE image is from a patient on the intensive care unit who is intubated and mechanically ventilated for pneumonia, and the question of intracardiac shunt with right to left flow was raised as she had an element of refractory hypoxemia. Here we have the same TOE from the same patient and we have a bubble study. So agitated saline is injected via a central line into the right atrium, and we can see it immediately crosses from the right atrium over into the left, demonstrating the intracardiac communication. Due to their small size and only intermittent transatrial flow, PFOs are often not visible on TTE, as was the case in this patient, and why we proceeded to TOE. In this next example, colour could be used to demonstrate flow between the atria. So this subcostal clip is taken from an elderly man who presented following collapse, and whose non-contrast CT head demonstrated ischemic stroke, and a CTPA demonstrated a massive pulmonary embolus. And that combination should always make you think about intracardiac shunts. Here we can see a mass within the right atrium which is presumably thrombus, and the intraatrial septum itself looks abnormal, and I suspect the thickening is actually thrombus sitting on the fossa ovalis. If we place colour over the intraatrial septum, then we can see a clear jet moving from right to left. A plausible sequence of events for this patient would be that thrombus embolized from the leg and lodging in the pulmonary arteries would lead to a rise in right ventricular and right atrial pressure, opening up the PFO, such that the next embolic clot would travel up to the brain. True ASDs, in which there's absence of septal tissue, are much less common. This TOE clip is an intraoperative study of a young patient undergoing surgical repair. This shows the most common form of ASD, which is a secundum ASD, and as well as showing flow across the septal defect, we can see that the patient has a dilated right atrium. Dilated right heart chambers is a consequence of ASDs with a large degree of flow, and ASDs are one of the things we look for in patients with right atrial and ventricular enlargement, especially if there's not another good cause. Ventricular septal defects, or VSDs, are most commonly found in the fibrous part of the septum, on the ventricular side of the aortic and tricuspid valves, and the most common type you're likely to find is the perimembranous. And these can either exist in isolation or as part of a more complex congenital condition, such as tetralogy fallow. Let's take a look at a couple of examples. So in this first clip we have an adult patient whose VSD is associated with pulmonary atresia. In the 2D apical 4-chamber view, the perimembranous VSD is just about visible, but becomes more obvious when we tilt the probe to find an apical 5-chamber view. Understanding the colour flow here can be quite challenging, so as always the solution is to slow down the clip, pause if necessary, advance frame by frame, and this will help you to see where blood is moving from and to, and during which phase of the cardiac cycle. In addition, you'll also encounter VSDs as complications of myocardial infarction. Here the defect or defects typically occur through the muscular portion of the septum, in the territory where the infarction occurred. Here we have the 12-lead ECG of a female patient who suffered an inferior ST elevation MI. She underwent immediate PCI but several days later deteriorated and became shocked. 2D echo shows us that the LV function is not too bad, whilst the RV is slightly dilated and is impaired. New hemodynamic collapse occurring several days after a myocardial infarction should lead us to actively consider mechanical complications, and in the context of an RCA infarct, posteromedial papillary muscle rupture would certainly be something to consider. And here we can see there is some mitral regurgitation, but based on this colour flow image, the regurgitant flow doesn't appear to be too severe. And indeed, her MR doesn't adequately explain the clinical situation. Here in the basal parasternal short axis view, we can see a physical defect in the intraventricular septum, which becomes all the more obvious when we place colour flow over it. This patient returned to the cath lab, where she had a percutaneous transcatheter VSD closure device placed across the defect. This clip is another parasternal short axis at the basal level the day after the procedure, and the bright VSD closure device can be seen straddling the intraventricular septum. Placing clips side by side from before and after the procedure demonstrate that the closure device has done its job and we can no longer see left to right flow. Another situation where you may find abnormal flow in the heart is when you have turbulence due to stenosis. Now, there are many anatomical reasons why you may have stenosis, but there is one specific case which is important for the level 1 sonographer to recognise, as it may radically alter your management approach, and that is dynamic left ventricular outflow tract obstruction due to systolic anterior motion of the mitral valve. Now, normally during ventricular systole, the mitral valve leaflets are opposed and well clear of the left ventricular outflow tract, allowing blood to be ejected from the left ventricle. When SAM occurs, the mitral valve leaflets, and particularly the anterior leaflet, are dragged by the flow of blood, such that they prolapse into the left ventricular outflow tract and obstruct the blood trying to leave the left ventricle. In these 3D reconstructions, we can see the anterior leaflet's A2 segment being lifted up and off of P2 in what has been described as having a dolphin's mouth appearance. This next clip is an apical 5-chamber view taken from an elderly lady on day 1 post-op coronary artery bypass grafting, and the ICU team were asked to see her because of precipitous hypotension. When we zoom in on the aortic and mitral valves and slow this clip down, we can see that just after the onset of systole, the anterior mitral valve leaflet starts to move back across the left ventricular outflow tract, almost reaching the ventricular septum and leading to a total obstruction of flow. This next sequence of clips are taken from an elderly gentleman who has suffered a traumatic brain injury and is intubated on ITU. In these parasternal long axis clips, the 2D image quality is poor, and it's challenging to see what happens to the mitral valve leaflets during systole. However, the colour flow looks abnormal. We have high velocity flow of the left ventricular outflow tract, and it appears turbulent. Remember that when we have normal laminar flow in the left ventricular outflow tract, as the flow of blood is almost perpendicular to the ultrasound beam, this tends to be displayed as low velocity, very unlike what we're seeing here. If we move around to the apical window and zoom in on the aortic valve in the apical 5-chamber view, then we can better appreciate how the mitral valve crosses the outflow tract during systole. Yet again, the solution to understanding the colour flow image is to slow it right down and then advance frame by frame. So here we have diastole with normal filling from LA to LV. When we advance to the onset of systole, we see the beginning of blood being ejected through the left ventricular outflow tract, and we can see laminar flow that's travelling at velocities that exceeds the point at which a lasing occurs, yet is still not particularly high velocity. Advancing further still, and we now have turbulent high velocity flow within the outflow tract. As we advance to late systole, we see another consequence of SAM. As the anterior mitral valve leaflet is pulled across the outflow tract, it lifts off the posterior leaflet, leading to posteriorly directed mitral regurgitation, occurring only in the second half of systole. LVOT obstruction caused by SAM is dynamic, and can be precipitated by certain physiological conditions. Having said that, there are anatomic features that will put a patient at risk of SAM. And if we think about the problem being the mitral valve leaflets getting too close to the septum during systole, we can imagine what these might be. So patients with left ventricular hypertrophy of any cause, but particularly patients with HOCM, where hypertrophy is often asymmetrical, favouring the intraventricular septum. Patients with elongated mitral valve leaflets, and certain characteristic patterns of papillary muscle placement, such that there's too much slack on the chordae holding the leaflets during systole. In addition, we sometimes see SAM occurring post-mitral valve surgery if an annuloplasty ring has been used to bring the leaflets closer together in order to treat mitral regurgitation. It's possible to end up with a coaptation zone that's too long, too much tissue, extending beyond the first point of coaptation. And cardiac surgeons will take steps to reduce the risk of this by sometimes excising wedges of tissue from the anterior mitral valve leaflet during mitral valve repair. In addition to those anatomic features, SAM is more likely to occur when the patient is hypovolemic, as the LV cavity volume decreases. Tachycardia and increased contractility will both add to this, and as you can see, that combination of hypovolemia, tachycardia and increased force of contraction is one commonly seen in critically ill patients. The detection of possible SAM in an acutely unwell patient should prompt referral for an urgent level 2 study, to confirm the diagnosis and measure the pressure gradient across the left ventricular outflow tract. Management strategies basically try to reverse those physiological conditions which led to the development of dynamic outflow tract obstruction, so giving volume to increase the LV cavity size, as well as slowing down the heart and reducing the vigour of contraction. Of course, it's important to remember that these are critically ill patients to start with, and each of these steps could potentially cause the patient to deteriorate. Therefore, this should only be done by somebody experienced in managing critically ill patients, and when using pharmacological agents, I would favour short-acting drugs so that the effects wear off quickly if the patient gets worse, not better. Finally, for this lecture, I'd like to consider how we assess the size of the aortic root. So in a comprehensive study, we'll measure the root in a number of locations, and the current 2020 BSc guidelines give us some normal reference ranges that have been indexed to patient height. In the still image, we can see a single measurement's been made across the widest part of a root, the sinus of Valsalva. Now, as I've stressed a number of times during these lectures, focus studies are supposed to be performed quickly, and intentionally there's few measurements within the minimum dataset. If you want to quickly eyeball the size of the aortic root, compare it to the left atrium and right ventricle, and broadly speaking, these three structures should have roughly similar diameters. If on visual inspection you're concerned, you can of course measure the transsinus diameter, and if you do so, measure perpendicular to the root walls between the two widest points, and the current BSc guidelines recommend measuring from the inner edge to the inner edge. For me personally, and for most people watching this video, I suspect it's completely impractical to memorise this table of normal ranges. So for my trainees, I recommend that they consider anything greater than 4 centimeters as being potentially abnormal and warranting further investigation. This still image is from a patient we discussed earlier in the lecture with type A aortic dissection and severe aortic regurgitation. Here we have a measurement across the sinus of Valsalva of 64 millimeters, which is grossly dilated. Okay, so that concludes everything that I wanted to cover in this lecture. So first of all, well done for getting to the end of it, and before we finish, let's quickly summarise those key points. So first of all, like with everything in Echo, start with your 2D. Have a look at the valves, have a look at the leaflets and the subvalvular apparatus when present, and think about leaflet thickness, how the leaflets move, how they open and then close, and is there anything adherent to the valves, any masses. Next, place a colour box over the valve and ensure that the box covers the valve throughout the entire cardiac cycle and extends into the preceding chamber. When there is regurgitant flow, make sure that the jet area is covered by the box, and don't have a box that's so small that the jet area goes out of the side and we don't see how far it goes. When you do find a lesion, think what are the potential sequelae of that lesion and are they present. So comment on both important positives and negatives here. When you're faced with a replaced valve or a repaired valve, the questions you want to answer are the same as those for a native valve. How does the valve function as a valve? Does it let blood through when it should? Does it prevent blood flowing backwards when it shouldn't? And if you're ever uncertain, pause your image and advance one frame at a time, paying attention to which phase of a cardiac cycle you're in to help you understand where flow is going. Valvular assessment is challenging, and it's expected that for most valvular lesions, you'll need to seek expert help of a level 2 sonographer to further characterise that lesion.